happens. So did everybody enjoy lunch? Okay, those who didn't came back, and those who were really having a great time stayed there. So, well, thanks for coming back. It means that maybe I provided some value somewhere in the last 30-minute talk, and hopefully there'll be something of value for you here also. Certainly an important topic, like Sherry mentioned, frequent flyers, and we need to start right there. And by the way, before you look at the slide and say, wait a minute, that's misspelled. That's the way it was delivered to me, and I looked at it. It's spelled either way, with an I or a Y, so you can do it either way. But how many of you in your departments are frustrated by seeing the same people come back for the same complaints over and over again, and you're making no progress with them? They're sucking your will to live. I mean, they really are. It's just like, oh my God, they are back again. But oftentimes you know what they need. You can really sort that out very quickly, and they don't need a lot of resources. But frequently we let our guards down a little bit, and we don't think that these people with chronic diseases and mismanaged or undermanaged diseases can't actually have bad disease, and they can. We've got to treat them as a new patient every time. Let's talk about frequent flyer programs, how it's a little different in the ED than it is here. So how many of you flew here? Okay, drive, did you drive? Oh, a couple people. Anyone walk? You live really close, sorry, that's a long walk though. So how many of you are United frequent flyers? I'm United, it's the Friendly Skies, right? I'm a one pass guy, and it is the Friendly Skies. I'll tell you what, except for the flight here, the asshole I sat next to coming out here was not. I'm sorry I had to say that, but I have to give you a public service announcement right now. I read an evaluation recently, and someone said, listen, Clower doesn't swear enough in his lectures. So I had to drop at least an A-bomb for you there. I do understand that I did follow Greg Henry and Billy Mallon, and so I know that they let it go a little more often. Maybe I need to flavor it up with a little bit of bad language. So the evaluation was like, yeah, he needs to swear more, and he needs to let his hair down. So apparently I've covered both of those, and we'll move on. So the United people, raise your hand. Okay, all right. Anybody like Continental better than United after the merger? Wish Continental was back. Yes, I'm right with you. Okay, American people, you're out there. Okay, I left US Air off because they will certainly be American soon. Southwest, you're Southwest lovers? Okay, yeah, that's great. They run a great operation. There's some great ones out there too. One that was only in the market for 3 years. People loved it. It's coming up. Delta people? I thought it was next. This one, are you aware this existed? Hooters Air. Do you know that they actually, this is not a joke. They had an airline. It was like for 3 or 4 years they had a frequent flyer program. It ended in 2006, and the airline failed. Some people said it was because they did not offer first class. I think it was because they had no class. I mean, but seriously, they existed. 737s like Southwest, but it just did not work out. So anyway, frequent flyer programs. Why do we treat our frequent flyers differently than people in business? In business, they're like, great, we love to have you back. You know what? We'll give you miles. Do you give people miles when they come back to the ED? You've flown with us again. Thank you very much. Do you roll out a carpet? Would you like to go through the preferred triage line? If you have preferred access, just come right through here. It would be an EMTALA problem, I understand it. But the point I'm trying to make is, we go, you are back here again. Why are you back here? I can't stand that you're here. No business ever does that wants return, repeat visit, and really considers their financial margins. Now, I know these patients we look at a little differently and say, but wait, they're getting no value. They have undermanaged chronic disease. It's a real issue, and they are presenting a problem. But they're presenting a problem because we've all ignored them, including us. They keep coming back, and we keep sending them out, and we keep getting the same results. And that is the definition of what? Insanity. So we're surprised. Oh my God, you're back again. Well, you didn't do anything for me last time, and I kept coming back. Expect me to keep coming back. You think they would go to someone else's department at that point. No, they keep coming back to yours. They like the maltreatment they get from your department. So hopefully we can do a better job. Look at some data here. American Medical News. 70% more likely to have poor mental health. Does that surprise anyone? These people do not have good mental health, but they need those resources. Another article, we'll talk about in more detail in a little bit, was published in the Annals of Emergency Medicine in 2006, really looked at the characteristics of frequent users, and I want to make a comment here. We need to get away from the term frequent flyer if we're not going to use it in a positive sense. If we're not going to say, oh, you're a frequent flyer, so you're welcome here, and we're going to do special things for you because you keep coming back to us, then let's call them something different. The newer terms out there are frequent users, overutilizers or superutilizers. Anyone have a superutilizer here? Somebody seeing maybe like more than 18 to 20 visits a year in your ED? Yes, so you've got some superutilizers. So those are the newer terms. Frequent flyer is looked at now as a derogatory term. Just be aware of that. You could offend some people, so be careful using it. 8% of all patients who used emergency departments 4+ times a year accounted for 28% of the adult ED visits. We cannot ignore this any longer. Once we have the data and know that they keep coming back and they're using a lot of resources and they're not getting better, then it's not like they're even benefiting from what we're doing. We've got to make things better. Back to this article in American Medical News. Spectrum Health Systems in Grand Rapids, Michigan. Anybody from Michigan? Oh, anybody from Grand Rapids? No, close though. Okay, so Michigan. They had a great plan. 950 patients, 10 ED visits or more, which equated to about 20,000 visits annually. $40 million was spent on these patients. They said, we cannot do it anymore, particularly when we're not providing any value or benefit to the patient. So their solution was, November 2011, they spent $1 million. Now, some hospitals might say, we don't have an extra $1 million laying around. Let's go back. You spent $40 million on a lot of people who might not be able to pay for their care anyway. So you've got the $1 million. You have the $1 million. They did a multi-specialty clinic that reduced ED visits within this group by 90%. Another way to do it is just piss them off. You know, I guess they won't come back anymore if you're not good to them, I suppose, but they're a very forgiving group, let's put it that way. No matter what we do, they seem to come back. All right, so let's look at Corey Waller's data. Annals of Emergency Medicine, 2011, 30 patients, a small group that had 10 ED visits or more. They gave them intensive medical and case management. What do you need from a medical standpoint, and how can we get social service involved to get you the resources you need so that you can get better and you don't need to come back here on a regular basis? You know, despite the fact that we think these people want to be in the ED, the literature supports the opposite position. They don't want to be there. They don't want 6-hour, 8-hour length of stays. They have other places they'd like to be. I almost said they have better places to be. That may not be the case, but they have places they would rather be for sure. So we want to make sure that we give them that opportunity. Insurer costs were reduced by 90% based on this program, and they had 1-hour preliminary physician evaluation followed by 5 to 6 30-minute follow-up visits. The patients were also seen by medical social worker at least one time and an average of 3 times. So they had intensive medical and case management. Look at this, $1.1 million for 904 visits in 2007, and just below $130,000 for 104 visits in 2008. Again, either they did a great job managing the disease processes they had and providing great resource allocation to them for mental health or whatever it was they needed, or they killed them with kindness. Oh my God, I can't take another visit with the social worker. I guess I just should not come back here anymore. One or the other. We don't know which it is, but it's probably that we did a better job taking care of these patients and identifying what their needs are instead of just treating them every time. No one else is doing this because they don't have great primary care access. So if we don't like what's happening, we need to embrace this and deal with it. And I think these programs can help us. The reasons for the visits. Inadequately treated chronic pain, 12. I wish we were going to have a talk just on that. It's a great topic to discuss chronic pain and how to deal with those patients. Opioid addiction, 6 patients. Significant underdiagnosed medical conditions, 5. Some of them just didn't have any transportation. So maybe we can adjust, that as well, and maybe get them some bus vouchers or something to go to primary care. Prescription drug diversion, underdiagnosed schizophrenia, and I will give you a quick story. I trained at Charity Hospital in New Orleans, and I am embarrassed to say what we did with overutilizers or high utilizers then. Do you guys want to know what we did? Okay, thank you. So I will tell you then, since you've asked me. Otherwise, we would skip it. I think it's a funny story, would not be accepted now, but this is honestly the truth. We had more than 24-hour waits in the emergency department every day. We would come into a shift, there'd be a stack of charts. As the charge resident, the resident in charge, you'd spend the first 30 minutes flipping through the charts, selecting a stack of people we might hope to get through during the shift. If you wanted to be moved up in the list, you had to have a medical crisis in the waiting room. Or your heart stops, we're going to move you up a little bit. We might move you up 2 or 3 spots. And if actually CPR or defibrillation works in the waiting room, we will find a bed. We'll figure out a way. So we had a lot of wait time. So when somebody came back 2 or 3 times in the same week or the same month, we did month-long rotations. Here's the 3rd time they've come back, we took up a collection. And I suppose it was a good idea to take up a collection to meet their needs, but that wasn't our goal. We would ask them, where do you want to go? And they might say, well, I'll just go downtown to the shelter. That's where we sent you last time. I worked 2 days ago, and here you are again. I'll never forget this conversation. How does Houston sound? Took about 25 minutes, but this person had been so many times, we collected a lot of money. I think patients even chipped in. Some of the other high utilizers chipped in also. And anyway, make a long story short, we got this guy to the Greyhound bus station, and he went to Houston. He never came back. So that's one program you can implement if you really have somebody in trouble. I know we have some people from Houston out there. Do you guys know, you know him maybe? But he never complained. So anyway, I wouldn't advocate that approach now, but really if you've got a difficult one to deal with, send them on an extended vacation. It might work. Okay, Annals of Emergency Medicine 2012. They looked at frequent utilizers. 7 to 17 visits were 9.9% of their ED volume that year. High frequent users, greater than 18 visits, were only 3.6, but the total, we're talking about, 13 or 14% of your ED volume. A lot of them had substance abuse. Many more visits to primary care and specialists when they had it available also. There's some literature out there to say they do have access to primary care, but they also go see them more often too. Maybe they're just more needy, or they're not getting their medical or their mental health needs met. Long history. 70% of them keep doing this. Only 17.8% that they note this is a new pattern of behavior. And as far as the substance abuse thing goes, as far as I'm concerned, when we're working and we see them all the time, we also want to be substance abusers. We want to start drinking. Oh my God, they're back again. They're stressing me out. I can't deal with all these chronic pain patients. So just like they said here, sorry, I can't find anything wrong with you. It's probably due to the side effects of the alcohol. And the patient says, well, fine, I'll come back when you're done drinking. So, all right. Now, percent of patients with various conditions. Just take a look at the list. I'm not going to recite them for you, but these are the high-risk entities that maybe are not emergent in our minds, but they also are definitely areas where patients are going to have return visits to the ED and their chronic disease processes are unmanaged. So if we identify they have one of these, if you're going to set up a program, these are the people you want to key into to provide resources for. Get them set up with case management. Let them know that they should have primary care follow-up. We'll try and provide that for them. And if they don't have any access to primary care, you may by default be primary care for them. So what do these people look like? What do chronic overutilizers look like? I know we all have a preconceived notion of this person, but here's one piece of literature from 2011 that really identified this. Brent Asplin and Jesse Pines came up with this. This is one piece of the article that they published. It's really high severity of illness. So they've got significant medical needs. They are older, not necessarily younger. Fewer personal resources. They don't have a lot of money. They've got nowhere else to go. They're chronically ill. They've always got something wrong. Present for pain-related complaints and have government insurance. So either Medicaid or Medicare. And this is what the high utilizer looks like. So again, this helps you to identify who they will be so that you can intervene to hopefully get them to a better place, not Houston, but to a better place medically so they're feeling better. And then by doing that, they will utilize the department less. I feel that the emphasis right now with emergency care providers isn't to provide better resources and to provide a better state of health for these high utilizers. It's to get them the hell out of the emergency department and not to have them come back. Am I mistaken? Raise one hand if you've never heard that. Can they just get them out of here? So I thought you were going to raise your hand. Just a little itch there. Okay. Your vote doesn't count, sir. You have to sit down to vote. Okay. All right. So let's look at this article. We'll go back to this one, Annals of Emergency Medicine 2006. So again, 8% of users with 4 or more visits equated to 28% of all adult ED visits. That's huge. And these numbers are repeated in study after study after study. This is what's happening. The resources are being consumed by a small percentage of patients who probably are not benefiting from the resource we're providing in the ED. Independent association with frequent use, look at the odds ratio. If you had poor health, well, your odds ratio was 2.54 to come back. So you're 2.5 times more likely to come back to the ED. Poor mental health, 1.7. 5 or more outpatient visits. Well, if you like outpatient visits, it stands to reason you're going to want to come to the emergency department at an outpatient location. Family income below the poverty level, odds ratio 2.36. No usual source of care, they're less likely to come in. But interestingly enough, in the same study, 84% actually had health insurance. and a usual source of care, 81%. So I think we always think that they don't have any source of health coverage, and that isn't the case. And there's some pretty good data out there too. JAMA 2000 by Dr. Newton. He said that, people who come back to the emergency department for convenience care more frequently do it if they're uninsured. But what he also pointed out is all people are frequently coming back to the emergency department for a variety of reasons. And those who are uninsured are coming back at the same rate of those who are insured. So the uninsured have gotten kind of a bad rap, and we have to be aware of that. Okay, another piece of literature for you. Let's take a look at this from 2011. Patient-centered intervention pilot. It was an urban public hospital. Ages 18 to 64, identified as likely to be readmitted. They enrolled 19 patients, so a small number. And you can probably pick a small number on your hand that you can say, if we intervened with these patients alone, the patients would be better off and the staff would be a whole lot happier. We'd feel better about things. So 19 patients, all male. 18 of 19 had substance abuse problems. 17 of 19 were homeless. I'm not great at math, but I'm thinking that pretty much means that most people who live in a box drink alcohol, or push a shopping cart, drink alcohol, something like that. So most people who are homeless, they're probably going to have substance abuse problems too. Admission, 64 versus 40. So they reduced the admission rate by 37% when they intervened. And they didn't even go into great detail about the interventions. The key is intervene, don't just discharge them. Get them involved with case management. Address their medical problems, and it helps. And the ED visits decreased also. All right, the hotspotters. This is a great article from the New Yorker. And you can pull this down online if you want to. It's easily available online. You don't have to pay for it. Here's the front page of it. Healthcare is costliest, 1%. And that's the key. The 1% of our population is consuming a huge percentage of our resources with very little benefit. And since they are coming back to us, we are the people who are likely going to be charged with dealing with this issue and this crisis. We can ignore it, like we have in the past. We can also take it upon ourselves to say, how can we keep them out of the ED to serve our own needs as opposed to serving the patients? But I think we ultimately have to say, they're ours, we own them, they keep coming back. They do have chronic medical problems, but we need to do something for them to get them where they need to be. So a high concentration of U.S. healthcare expenditures in these patients. It's also identified in this article from issue 19 from HRQ. So in 2009, they said 1% accounted for 20% of all healthcare costs in the United States. 1% of the population. This is great data to stimulate us to do the right things. That was $90,000 a year per patient that we're spending on these people. Is that amazing? You talk about end-of-life care, and sometimes you think, well, maybe if there's feudal care at the end of life, we know about Medicare expenses, maybe they'd rather go on a cruise with that money instead of have all this money spent at the end of their life. Maybe these people that have $90,000 a year spent on their care, maybe say, hey, listen, I'll buy you a new vehicle for $20,000 if you just don't come back to the emergency department for a while. Maybe that would be money better spent, I don't know. But the key is we're spending a lot of money on people, and the return on investment is very small. 5% accounted for 50% of healthcare costs, and the converse was true. Only 50% accounted for only 3%. So it makes perfect sense. Those 5% are really, really using a lot of resources. The IMS Institute and IMS Payer Solutions examined healthcare spending, and what did they look for? They found that 1%, patients in a survey of 10.6 million health plan members, so people who are insured, accounted for 25% of their plan's costs, and 5% accounted for slightly more than half. So we really know where we need to focus our efforts on. And the reason I'm giving you all this information is I want to provide you the data so you recognize this is truly a problem and an issue, and we are the most likely people to fix this. This is a financial crisis for the healthcare system, and we can't ignore it any longer. And our opportunity to fix it is probably greater than anyone else's. So, Doug Eby, still in this Hotspotters article, what he said from Anchorage, Alaska is, here are the hotspotters, the people who are going to have a lot of recidivism, people who are going to come back to the emergency department, chronic mental illness. We need to find resources for them, and I'm hoping the federal government will recognize that and provide the resources we need. The medically fragile. So I guess people who are ready to bend and break, so be careful with those people. Diabetes, congestive heart failure, the people who we know are going to come back for readmissions. And the socially disintegrated. I'll tell you what, I think that's an interesting term. I'm not exactly sure what that means, but I kind of get a sense of it. I'm not sure if you really understand it either. Maybe it's like that old definition of pornography. I'm really not sure what it is, but I know it when I see it. And I know socially disintegrated when I see it. So I don't know. I'm seeing a little bit of it right now after lunch. I think you guys should have eaten a little less. But they said self-care, few family resources, and very dependent personalities. They like to be there because they feel supported and they feel better about things. And actually, Bruce told me about a frequent flyer he had in one of his departments many years ago, and he's going to tell you. I think you're going to share that story? Okay, good. So we're done. It's one of those dependent personalities, I think. All right, you got the background. It's painful. It's ugly. It's depressing. But now let's talk about any solutions that might be out there. Robert Wood Johnson Foundation. Hey, October 11, 2012, they said, we're going to submit some money. We're going to put money behind anybody who's willing to come up with a project that makes sense to address the issue, and I applaud them for this, addressing costs of superutilizers. Again, none of these researchers, none of these publications are using the term frequent flyer anymore because it's regarded as a derogatory term toward patients. All right, so take a look. I'm not going to read these off to you. There are a bunch of them. But basically, these 2 pages list several of these initiatives that really focus on case management, managing chronic medical conditions, providing resources, and intervening at the right time. They have different flavors, they have different approaches, but you can look at them in the syllabus, and there are several of them. And I don't know if money's still available, but I know that they didn't exhaust the full $2.1 million. All right, how about this article from Annals of Emergency Medicine 2011? A systematic review. They looked at 11 studies, 3 randomized controlled trials, 2 controlled trials, and 6 non-controlled before and after studies. So we have a population of patients who are overutilizers. We implemented a program, and we studied them then after. Was there a change? Although it may not be the best methodology, certainly is still great value for us and great information. Case management was the most commonly studied intervention. 6 of 8 before and after studies showed reduced ED visits, but 1 showed increase. So I don't know what they did with their case management. I don't know if they fed them more, the food was better. They decided to come back more, so that was kind of a failure of their experiment. And cost reduction in 3. Homelessness reduced in 3 out of 3, which is good. We certainly want to find people homes if we can. Clinical outcomes, nothing statistically significant, but a positive trend for better clinical outcomes in 2 of the 3 studies. Certainly not landmark studies, but there's not much data out there on this topic. What this data tells us is we have a problem, and when we try and intervene and fix it, we largely do good, and we don't waste our efforts. So there's great value in that article. What about a chronic pain program? American Journal of Emergency Medicine, May of 2007. This article was published. I like it, and I don't like it, and I'm not schizophrenic off my meds. It has good points, both directions. So patient identification. They found they're high utilizers. They sent letters to the patients. Anyone do that? We know you come here a lot, and we're just letting you know we're watching you. You got to be careful with that. The other hat that I wear from a risk management standpoint worries me with EMTALA implications. If you send a letter saying, hey, we understand you have an undermanaged illness, we want to help you, we want to get you into case management, next time you come in, we're going to enroll you, those are all good things. If you say, don't ever come back here again, or we understand you keep coming back for chronic pain, we refuse to treat your pain when you come back here, those are potential EMTALA violations. You have to be very careful how you word those letters. So be careful. Non-narcotics used in subsequent visits, it worries me about this one. So regardless of knowing what they were coming in for, the goal was, we're not going to treat your pain with opiate analgesics. How do we know they need them or don't need them? And if you look at the data that's out there, there are a huge number of patients with chronic pain that are undermanaged and have pseudo-addiction. The pseudo-addiction means you have addictive type of behaviors, but as soon as the chronic pain is managed effectively, all those bad behaviors go away. So we have to be mindful that this is a mental health condition. So just telling them, well, we're never going to treat your pain effectively when you come in. There's certain drugs we won't use until you evaluate them and determine that it's not effective or appropriate for them. Hard to blanketly say we're never going to use this medicine in this class of patients. Primary care follow-up for alternatives was suggested, so they put that in the letter as well. It did decrease in ED and primary care visits. So I like the idea, maybe getting them to the right place. But the goal shouldn't be to scare them off. When you come here, we don't like you and we're not going to treat you anyway. Yeah, I wouldn't go back either. But what we need to do is make sure that we're letting them know we've identified you as high risk. You are a high utilizer. We need to change the pattern. And changing that pattern means trying to fix you, not trying to turn you away. That's the key. Now, we had a great director that put a program together a few years ago, and in our last 5 minutes, I want to highlight this for you. You want to see this program because it worked. This is an actual program, I think, that worked, that wasn't just designed to say, you have chronic pain, and we just don't want to see you back here for this. It can't be about our bias against chronic pain. It has to be about providing better care for the patient, even if chronic pain isn't the thing we like to take care of most of all. We still have an obligation to these patients. So pain medication doses administered per 100 visits. They had initially, when they looked at this, in the Carolinas, 83, 36 was non-narcotics, then they had in the 20s was oral narcotics, and then parenteral narcotics was 19, almost 20. So there's the breakdown initially when you look at per 100 visits. That was the demographic of that department. Now, description of their process. Controlled substance review panel was put together. Intention was to select patients who are not best served by receiving narcotics in the ED. Now, I would ask you to change your terminology a little bit too. At a recent ACEP board meeting, we had a good discussion about terminology. These are opiates, they're opioids, but if you look up the definition of narcotics, those are illegal substances. So we probably want to move away from the term narcotic and use opiates or opioids. So patients were nominated by the ED staff. Interesting process. I'm going to nominate you. Well, that makes me feel good, too. I'm a frequent flyer being nominated. That's great. Over concern about patients with recurrent ED visits, 6 discharge ED visits with subjective pain complaints. That made the list. Criminal drug history and doctor shopping. If we found those things, those were qualifiers to get nominated. Here's a process flow diagram that I have for you. You can take a look at, but just basically what they did. They nominated a patient, looked at the ED visits. If they were significant, they sent into the multidisciplinary panel for review. If there's a criminal history, yes, they just had a nice flow chart of how they dealt with the nominations. And here's the panel. And Vic Parwani was our medical director, still is, and did a great job, and he headed this process up. The reason I have this slide up here that he provided for me is to show you how many people touch this process. The nursing director, some of the nurses, risk management, case management, other specialists, mental health, everyone's involved, and it worked. And this was focusing on high utilizers who had chronic pain only, not all high utilizers. So initial review, 53 patients were nominated in the first 48 hours after announcing the program. You imagine the staff were stuffing the ballot box. I've got all my favorites. 1 vote for customer. 36 patients were selected for inclusion. They found 36 that they were most likely to help. 25 of 53 patients had drug-related criminal convictions. Remember, when you get into drugs, if you're addicted, it's still mental health, but then you tend to do things bad or wrong to facilitate the habit. Just because you have a criminal conviction does not mean that we turn them away and that we don't think they're important patients for the emergency department. It shouldn't mean that. We help everyone. We're the safety net of the healthcare system. All right, patient review. 3 meetings at the point this data was put together. There have been more since that time. 92 patients were reviewed. 73 were selected. And take a look. ED visits pre- and post-intervention for the 36 that were originally selected. Originally, pre-intervention, 185 visits. It dropped down to 102. So they had less visits, which was a great value. And 31 had decreasing ED visit frequency, and 27 of the 102 visits had narcotic analgesics. So they were able to manage the pain elsewise, some other way without using opioid analgesics. But at least they didn't tell them, don't come back. We're going to look at another way to treat your pain, which is reasonable. We just don't want, in my opinion, others, legislators or policies, to tell us how to take care of patients at the bedside when this is a very complicated process. I think we need to be responsible how we prescribe, but I think we need to practice medicine and nursing at the bedside as opposed to being told that for all patients you will treat them the same way. That doesn't make a lot of sense. I just throw this out here to show you the documentation they kept on the information they found on these patients so they could track them. And this got local media attention. Look at this, the News-Times in Carteret County. So they were in the paper that, hey, they're trying to make things work better. They did some advertising. Hey, prescription drugs can be dangerous. Keep them in a safe place. They're getting the message out that this is a problem in the community. And ultimately, This is a difficult problem, and I know it's hard to deal with high utilizers and chronic pain patients. But remember, when your day seems really bad, it can always be a little worse. All right, thanks everybody.